Okay, so here's our heart again, all right? So, we went over now kind of our normal blood flow. So we have to understand normal and healthy before we can look at any of our pathophysiology, right? When we start looking at disease processes, we have to understand what normal and healthy look like, all right? So if you haven't already, make sure you review, you have a good understanding of kind of this normal cardiac blood flow. So if we take a look and we look at like our congestive heart failure, okay? So congestive heart failure, when we look at this, there's a couple things we want to address. So if you go to the gym and you lift, right, and you go and you lift your biceps, get big and strong, right, we have that hypertrophy, and now you get big biceps, look like Popeye, right? So now what happens is you start to build those muscles, they get bigger, and that's kind of what we know. Remember that the heart is a muscle. Okay, when we look at conditioning the heart, we look at like aerobic activities. So for some other reason, you go to the gym and you run on the treadmill or you do any of those ellipticals. We start to look at that cardiac conditioning. What we're doing there is we're conditioning the heart to be able to do its job, to contract and beat. So we're looking at it to be able to keep doing its function when it is deprived of oxygen. So that conditioning now is healthy, and that's one of the things that aerobic activity and activity level in general help reduce some of our risk factors when we start looking at high blood pressure and high cholesterol. How do we make our heart healthy? So that's good for the heart. When we look at congestive heart failure, the problem there is the heart is a muscle, and what's happening is we're going to look at right versus left-sided and kind of the contributing factors, and what we're going to see is that the heart is going to build this muscle from being overworked, okay? So if we kind of start on the right side, all right? So what happens is when we have somebody with right-sided heart failure, what we have now is they start to build this thickened wall, right? So kind of like we said, you go to the gym and you lift your biceps and you get big biceps. The heart now, when the right side of the heart is having to work really hard to do its job, the muscle, right, the heart muscle, is going to start to thicken. So we start to see that the heart builds its muscle in this way on the inside. So now what it's done is it's decreased the amount of area we have for blood to be pumped from the atria into the ventricle. So now, if we have less blood entering the ventricle, the heart has to pump harder and faster to get the same amount of blood into circulation. Make sense, kind of? So when we look at kind of what would contribute to this, right? When we talked in our respiratory, and we talked about our COPD, all right? So our chronic obstructive pulmonary disorders. And we talked about, through that whole medical module, we talked about these chronic progressive diseases. Chronic means over a long period of time. We're talking years of this development. When we talk about progressive, it means that it worsens over time. So people can do a lot of things to kind of manage their symptoms. So early recognition of these diseases, lifestyle changes, those are all things that can help us mitigate and kind of manage these symptoms, slow the progression. Okay. In a lot of cases, what we see is these chronic progressive disorders, they start to cause exacerbations of other symptoms, right? So exacerbation means make worse. So you start going to pick up your patient from the hospital and you start seeing that they have a medical history of COPD and congestive heart failure. Like, how do you end up with kind of both of these? So when we look at our COPD, remember we're looking at our chronic bronchitis, and we're looking at our emphysema. Under our COPD is, that black lung. We don't talk a whole lot about it. These are kind of the major two that we're looking at. Asthma is not a COPD. Remember, it's a reactive airway disorder. It's episodic. Somebody who has an asthma attack, they have a flare-up, they have an episode, medications, they're able to kind of get back to their baseline. Their baseline is always going to be a little bit less healthy than somebody who doesn't have asthma, but it doesn't continuously progress like an emphysema or a COPD, all right? When we look at this here, the problem we have with the COPD is that the problem is in the lungs. So we talked about the right side of the heart is that pulmonary circulation. It's now pumping to the lungs. So if we have increased resistance, in our lungs, over time, this right side of the heart is working hard to pump against this resistance, pump and pump and pump and pump. And eventually what happens is this muscle starts to thicken, starts to strengthen to be able to keep up with this, and this is where we start to see this right-sided heart failure. This is why a lot of times you see right-sided heart failure referred to as cor pulmonale. Okay? So we look at that, pulmonale, looks like pulmonary to me, right? So now we're looking at it's pertaining to the lungs. So not 100% of the time, but now what we start to see is when we have this chronic increased resistance in the lungs, we start to see the right side of the heart start to compensate for that, and over time we start to see it start to fail. So it compensates as long as it can, and then we start to see problems. So when we start to look at this here, if I start to have a smaller space for this blood flow, for this to be able to pump out, so we start seeing backflow. So now we have blood that's, it's coming this way into the right ventricle, and it's coming this way. Same thing in the right atrium. We have blood still coming in through the superior and inferior vena cava, and now what we have is it's going backwards and it's coming in. So now what's happening is we're starting to get congestion. We're starting to see what happens is as we trace this backwards, when we come out here, now what we start to see is when it gets out to the superior vena cava, that's going to now cause backflow out into our jugular veins, right? So now we start to see our patient have JVD. So one of the symptoms of right-sided heart failure is JVD. When we look at that inferior vena cava, that now also, is fed by the hepatic portal. So now we start looking at the liver. Remember that the liver, the spleen, incredibly vascular, lots and lots and lots of vasculin there for it to be able to do its function. So when we start to have backflow, and we start to have that backflow into the liver and the spleen, this is where now we get that ascites. So this is where now we have the swelling of the liver and the spleen. They start to get that big belly. So they have kind of that hard, pregnant belly. It's filled with fluid. Okay? So they start to get that big belly. They have that JVD. And then we start to see dependent edema. Okay? So now with the dependent edema, a lot of times this is where we check when we start to see it in the ankles and the shins. We start to see pedal edema. If we have somebody who's bed confined, we can start to see it in the sacrum, so we can start to see it in the lower back. We start to see that edema, that swelling. So this is where now what's happening is we have blood going the way it's supposed to, and it's coming in the opposite direction. So now it causes this engorgement of the vasculature, and we start to have the plasma, the liquid portion of the blood, starts to leach out and cause this edema. Okay? So now we start to see the engorgement of our veins, we start to see the engorgement of our liver and spleen, and we start to see this dependent edema. So when we look at our patients and we see that they have these symptoms, we're starting to think that this is that right-sided heart failure. Okay? Now, when we look at left-sided heart failure, one of the most common things that we're looking at is, especially at kind of a BLS level, is we're looking at this being caused by an MI, right? Myocardial infarction, a heart attack. So if we have a heart attack and I have a part of the heart muscle that dies and no longer is able to function or do its job, again, the rest of the left ventricle has to pick up the slack. So now the left ventricle, this is where now it's pumping blood into the systemic circulation. So workhorse of the heart, again, over time, it's going to compensate, it's going to work hard. The rest of the heart is overworking to pick up the slack, and now we have the same thing. Now what we see is on the left side, we start to see this thickening of the wall, and again, it's on the inside of this chamber. So now same thing here, we have less area for that blood to return and to be pumped into circulation. So now what we start seeing is, it has to work harder and faster. And then the same thing eventually happens. We start to see this backflow, and then we look at it's, we have our pulmonary vein that's returning oxygenated blood from the lungs. So now eventually we follow this backwards, and now we see that this is starting to go backwards into the lungs. So now this is where we start to see that pulmonary edema. So now all of a sudden we have a patient, and these are the ones we get pretty frequently, 1, 2, 3 o'clock in the morning, they wake up, they feel like they're drowning, and it's because they have all this fluid in their lungs. So now we listen to lung sounds, and we have our rails or our crackles, same thing, right? We're starting to hear that fluid in the lungs. And now we have a patient whose blood pressure is really high, they're struggling to breathe, and this is where now, if it's within our protocols, CPAP works really well for these patients. Helps reduce that work of breathing, helps displace the fluid out of the alveoli, so we increase that surface area for gas exchange, so we can reduce that hypoxia. So this is where CPAP works really well for these patients who are struggling and having this exacerbation of this left-sided heart failure, this pulmonary edema. All right. Most of the time, while this is happening, their blood pressure is really, really high. So we also don't run into that contraindication of that hypotension. All right. Patients who have chronic diseases, they don't call us right away. They try to manage them. They do not want to go to the hospital. So by the time we get called for these patients, we're already well behind the 8 ball, because they've waited to the last minute to call us to be like, nothing's working. So if we start to look and we're starting to see this backflow, and we see this pulmonary edema, we're now starting to think left-sided congestive heart failure. When we have symptoms of pulmonary edema and are right-sided, this is when we now say that this patient has total heart failure. Okay? So, a lot of times we start to see these questions, and, when you look at your national exam, they're asking you scenario-based questions. So it's not kind of like throughout the program where they're asking you, all right, well, what's the definition of hypertension? And, what's, why would, what does this vital sign mean? What they're looking now is they're telling you, Mrs. Jones calls you because, she's starting to have some, shortness of breath. So now they come in and they give you the vital signs, and they start to give you some of these symptoms. And they're asking you, so what's wrong with Mrs. Jones? Does she have right-sided heart failure, left-sided heart failure? Is she having an MI, or is this COPD? And now you have to, based on the clinical presentation of this patient, be able to determine what's wrong with her, because that's what we have to do in the field. We have to be able to go out, look at our patient, do a good assessment, come up with kind of a working diagnosis of what we think is wrong with the patient, so that now we can pick the appropriate treatment, right? The treatment that we do for these things is different. If we pick the wrong one, we can do something that's harmful to the patient. So being able to recognize these things in a clinical setting is important. That's what that national test is. They're really looking to kind of bring this together and say, okay, what's the practical application? Are you able to go out and make a good clinical judgment? Can you make a good clinical decision about the correct treatment, modalities that we're going to use to take care of Mrs. Jones? So you want to make sure that you're comfortable with this, but like I said, you have to understand healthy before we can start to look at this pathophysiology. So I have to be able to recognize in a sick patient that if I have somebody who has an underlying, chronic bronchitis, and now they also have a right-sided heart failure, something as simple as a cold could line them up to now be admitted to the hospital, because they have, when we talk about those underlying health conditions, now we start to see patients who are on lots of medications, patients who have really significant medical histories. So we want to make sure that we're able to understand that and kind of put this all together. All right? So hopefully this is helpful, and if this is something you have to kind of watch a couple times to understand, make sure that you do that, because this is definitely something where not only do you need to be able to recognize it for your test, but these are the majority of our critical patients. So when I get a call at 3 in the morning, I know for shortness of breath, I'm already thinking in my head that we're going for a patient with congestive heart failure. They got pulmonary edema, and I'm already thinking of my treatments in my head. So when we show up, now as we start to do our assessment, we already kind of have an idea of what we think is going on. We never want to just kind of, become, put blinders on and walk in with the shortness of breath at 3 in the morning and be like, oh, it's going to be congestive heart failure. We still have to do that assessment, but now you're starting to look at some of these patterns that we start to recognize. All right? So hopefully this was helpful. Feel free to, watch this, more than one time if you need to.